This material is made available to you by or on behalf of the University of Melbourne under Section 113P of the Copyright Act 1968. It may be subject to copyright. For more information, visit the University Copyright website.
Thank you, Bronwyn. It's a delight to be here and to talk and share with you the rationale, I guess, behind this OPUS CRE. So it has been said that osteoarthritis is a very wicked problem and one which is difficult to solve, primarily because by the time the patient comes to us, there's such fixed and established physical abnormalities, whether it's the joint, bone, ligaments, muscle, whatever you like. And there are huge and competing, I guess, opinions and protocols as to how this should be managed. What we do know is that despite the fact that it is so common condition, the management of this really continues to challenge us. And whilst in the past, perhaps only 50 years ago, people died of war, pestilence and poverty, we're now really suffering the burden of excess, whether it's excess life, whether it's excess weight, or is the excess of self-induced trauma. And as a result of that, osteoarthritis, even 20-odd years ago, was already showing itself as being highly prevalent in those over the age of 60 and 65. And if you look at the latest global burden of disease study, you'll see this huge smudge of purple. And that is actually musculoskeletal disease. And you can see the bulge is towards middle and older patients. So the demands on our community really going into the future are there to be challenged. If you look specifically at the types of causes of disability, what you find is osteoarthritis over the last 2 decades continue to rise as a global cause of disability. And when you add to it the spinal abnormalities, in this case neck arthritis, you can see it's starting to dominate and getting very close to major participants in the first top 10 of causes of disability. Here in Victoria, 1 in 6 patients have, 1 in 6 people, actually representative of Australia, 1 in 6 people have osteoarthritis. And if you take back pain separately, another 1 in 6. So when you add them together, there is a substantial number of people who do have musculoskeletal disease. And as Jane alluded to, they are then combined with circulatory, mental health, asthma, diabetes, chronic obstructive disease, a whole bunch of different things. It is really quite central, but the problem is we don't focus on it. It's everywhere. Half of all those over the age of 60 have got arthritis that's being treated. But it's not sexy. It's not really the sort of thing that jumps out and gets you. And because of that, we live with it and we live with the problem. And it's very difficult to solve a problem that you live with. So joint replacement surgery is a very good solution to the problem of established arthritis. Not saying that because I enjoy operating and I'm an orthopedic surgeon, but in fact it is. And it's been shown in numerous studies that if you look at the recovery and what it does for people disabled by the condition, it is actually very good. And if you look at the cost effectiveness of this, it is also very, very good. And as such, the evolution of the discipline of orthopedics and the use of prostheses continue to advance, such that now we can do very good revision surgery, very good complex deformity surgery, and get away with the sorts of results that we wouldn't have dreamt of just a few short years ago. When you look at our National Joint Replacement Registry, we show that the chances of having the same prosthesis in almost 20 years from insertion is about 90%. When I started doing orthopedics, we said to patients, at 10 years, you're going to have to look at getting it replaced. That's now doubling out. And when you look at this graph here, which are the age groups in which joint replacement is done, what we're seeing is there's a rise in the number of people over the age of 90 now having joint replacement surgery. Definitely 80 to 90, and obviously the very large group of those under the age of 80. But for those patients over the age of 90, we're getting them out 5, 6 years after joint replacement. So we're having a very significant impact on quality, and we know that quality of life now really extends across the spectrum. The question then is when to do these things. So all the benefits of joint replacement surgery brought together in this article by Ian Learmont and Cesc Rohraback, and And they really raised the profile of joint replacement, calling it perhaps the procedure of the century. Because it took someone completely crippled and disabled both by pain, deformity, dysfunction, and made them gainfully employed again, a very active member of the community. And so, like everything that's really good, you set yourself up a little bit, and what happens is the rise and rise and rise of activity in this area. And as you can see from the results of the National Joint Replacement Registry, we are now up to 100,000 joint replacements a year. So, and that continues to rise. It shows our reliance on this in a community where osteoarthritis is impacting the community. It shows the confidence which surgeons would have. It shows the confidence the GPs would have in referring for this style of care. But we need always to stop and take stock of the impact downstream. We know that the health budget is 10% of GDP. We also know in Australia that's 10% of the health budget is MSK. We know that 10% of all hospital costs is TJR, and that's 50%. Acute care is 50%. So surgeons have a huge impact on the health and the GDP. And as Stefan, I think, once said, when we change the way we practice in joint replacement, there's a blip on GDP. Imagine that's just one condition. We change the way we do something, you see it read out in the GDP, the impact on the GDP. So we have a very important role as clinicians, as surgeons, as people who are part of that stakeholder team to really make wise decisions about what we do. And putting it into a global perspective, if 1 to 2% of GDP in developed countries is related to musculoskeletal conditions, and added it all up, it would be the 11th largest economy in the world. That's how much money is being spent. And that raises the stakes for us in terms of responsibility and accountability. And of course, when you get rooms together, groups of people together in a room, why is this so? What's driving it? Stakeholders from insurance to clinicians to industry to efficiency to government, everyone's got a reason why it's being driven. There is not one single truth. It really is a combination of all of these things that are impacting. So where are we today? We have this tension between evidence and practice. We have a tension because we practice a lot of things that in our hands work. And when a surgeon says to you, in my hands this works, it means there's no requirement for evidence, because it does. Because I believe in my waters these things are true. And we have to be very, very careful about that, because what we would like is high-level evidence. What we actually have is low-level evidence. And worse still, we have eminence-based medicine. People like me who come up to the podium and tell you this is how it should be. You know, and everyone does it that way. What we need to do is really interrogate the evidence and drive it, because we have no other choice now. The impact on our budget is so great that perhaps the quality of care is not so important as to make sure that we can actually afford to do what we're meant to do next year. So that is actually taking primacy in a lot of work that we do. But what do we have? We have workforce that, you know, the cognizant, the dissonance is strong in this one. If it doesn't fall within my beliefs, well, it couldn't be true. And I tell you what, I'll find the evidence to show you what I'm doing is true. You know, there's a lot of this happening in science, and particularly in medicine. And I must say, as surgeons, we are the strongest proponents of these two qualities. So what is being done right now? There's a lot of research being done, looking at the patient and how interactions with these various areas improve care. That's currently what we do when I look and review grants for research, or look at what people are doing or reading. Is very isolated. And there's a lot of exceptionally good work being done out there. But the question is, you know, why isn't it working? Why are we doing the same thing today that we did 20 years ago that we did 20 years before that? And it's because it's almost like the Mercedes-Benz sort of, the car manufacturing. Every year there's a little change. And if there's only a little change, you don't have to change. It's your choice. You know, maybe it's metallic black this year and then it's matte black next year and we don't really care. It's until you have a big paradigm change that people think, oh yeah, this is getting old, let's move on. But big paradigm changes are what we need, and they actually hurt. It's ripping off the Band-Aid. It really, really hurts. So people avoid it. And they avoid it by incrementally improving and then refuting the incremental improvement, as it were. So how should we think about this? Well, Singapore to Melbourne is a fixed distance, and if you fly it, it's about 6 hours. But some days it's 8, other days it's 7.5, sometimes even less than 6, 5 3/4 hours. So what buffets that journey of a fixed distance is the weather, other forces, is the fact that a country says you can't fly over our country, the corridors are closed. Things change all the time, the headwinds, whatever you like. And so the patient's journey is actually a little bit like that. We cannot take into isolation how we are treating the patient without considering all the other things that influence that journey as well. I may have the perfect treatment for my patient, but if they get cancelled on the day of surgery, there's the expense, there's the delays, there's the blocking of another case that could have been there. There are so many things that we should be thinking about, and how do we integrate this into new models of care? So what a new paradigm would challenge is currently what's being done by the addition of these influences. One of the things that it needs to be said as well, and really 5, 6, 7 years ago was already being highlighted, is the appropriateness of what we do. And if you look at the different conditions, here's osteoarthritis, only 1/2 of what we do, this is in Australia, is regarded as appropriate management. That is osteoarthritis as a whole, which means there's another 1/2 in Australia that is not being done appropriately. What other things do the evidence show? That in this thing that we would call the operation of the sanctuary, that has remarkable results and cost effectiveness, 1 in 4 people are simply not happy. And if you're talking about an industry that between 5 and 10, by the time you add the indirect cost, $5 to $10 billion, let's say we didn't operate on 1/4 of those because we could predict that they were not going to do well. Let's say we didn't operate on 1/3 to 1/4 of those because we knew they were inappropriate and should not have been selected. How much money could we potentially be saving to be used on other things that is required? So, you know, some treatments are just simply wrong. Last night we were having a conversation about sham surgery and, you know, the benefits and the risks, and maybe something we believe is absolutely appropriate is not working, absolutely wrong, and more importantly, does harm. We're paying for all that if we're not more discerning about what we do. So what should we be focusing on? We should be focusing on really promoting high-value interventions. We should really be ensuring that routine treatment that has evidence behind it, that is producing an impact of great significance and benefit, should be what we're trying to do. We should be reducing, getting rid of low-value interventions. I know there's a lot of work on that at the moment, but more importantly, we just need to do a lot of house cleaning here. Between 1/5 and 1/3 is waste, is complications, without even being innovative. If we just tidied up this end, we could save 1/3. So you could see what the challenges are. This is our challenge. We haven't even begun to look at that. This should be our challenge. Then we spend the money innovating afterwards. And why is it important? Because it's all about sustainability. We are practicing unsustainable healthcare at this moment because no one is checking us. Of course, we're nipping, the dogs are nipping around the ankles and we have a bit of haircuts here and there, but the reality is we cannot practice the way we are currently practicing. So what drives OPUS is to have a look at safety, evidence, the cost, efficiency and effectiveness with the patient right at the centre. Using patient-related outcome measures. What are our goals? The goals of this CRE is to really look at redesigning the health care system. Let's be bold, let's be arrogant, let's think about the future. We want to change health services with the patient at the centre of healthcare redesign. The next most important thing we want to do is to build capacity and capability. The next army of people who will take this challenge forward is what we need to be doing, because it requires a national army of people interested in this to do something about it. So, back in 1998, we made a decision that big data was everything. So we patiently collected data, recognizing we would probably not do anything with that data for the next 5 or 6 years until it matured. And so that was the start of the St Vincent Melbourne Arthroplasty and Outcomes Registry, for which Michelle Dowsey has had an amazing impact in refining and developing to what it is today, the SMART Registry. And it's the SMART Registry that has now over 11,000 procedures in 9,000 patients, 100,000 surveys, that gives us insight into the behaviour and performance of joint replacement in an Australian community. It is a unique registry to Australia, perhaps one of only a handful in the world that has such deep data. This is a national asset that is going to allow us to really make the inroads that we wish. It is a high-performing registry. It gives all sorts of information about patient and procedure-related data, containing the sorts of things that allow us to interrogate. So we have collect pain and function. We have 100% baseline data. We are collecting almost 100% at 1 year. We have over 85% at 5 years data, which is unheard of for an orthopaedic-based one. This is not a blunt post-marketing surveillance registry. This is a research registry. And we know what happens to those who are lost to follow-up. Like the Swedish population-based database, we know exactly what's happened to everyone, which home they're in, which, plot they're lying in, everything. And what that has allowed us to do is to allow us to collaborate. Having an asset means you open the asset to collaborators. You open our valuable asset to the nation, to the world. And we've been able to really build very, very strong alliances. And that has actually set the platform for this CRE. So what are we actually talking about? This CRE looks at getting a patient who's infirmed and currently dissatisfied by asking specific questions. Is patient selection appropriate? Are we aligning patient and surgeon expectations? What are the non-surgical alternatives? And if they were to have surgery, what are the drivers that impact on the efficiency of getting them through, making it more available for others? So we have various work plans, and you will see some of that being presented today. Developing nomograms for predicting response, identifying drivers of choice. You'll hear about the non-surgical alternatives. And of course, we've got grants also looking specifically at developing enhanced programs of care delivery. We're using a whole variety of different methodology, from prognostic factor development, increased choice experiments, various other therapies, as well as hospital services research. And at the end of the day, we hope to get someone in that position, and we hope to do so by making sure they're the right patient at the right time for the right procedure, making sure that whatever they get, access to care is enhanced and therefore equity across Australia, making sure they are fully informed about what's happening and they're engaged with the whole process. They're actually empowered to own part of that journey. We want patients to be satisfied with reduced outcomes, and we want to have improved efficiency with all that. And so we were able to pull together from all our various grants and all our various collaborations over the years. We set the stage for this, and I'm lucky enough to have some fantastic people who are part of this CRE as our leads. And if not for them and their teams that span this nation, we would not have the powerhouse that we have. And of course, it's not just the leads, but the associate investigators, the next generation of people coming through, the postdocs, the people who for a variety of reasons could not be our leads, but we wanted them in anyway. We wanted them for the skills and expertise that they had. They do more than just provide that skill. They provide mentorship, supervision, and a connection. And then to make this a reality check, It was very, very important that we had a stakeholder advisory group, people of great prominence, they are the opinion makers, because their experience has allowed them to know when we're fibbing, to the reality check of, you know, that's a bit far out there, this is what Australia needs or not. It's really important that we have those people with us, and especially the community groups who need to say, yeah, you're going where we need you to go if you're trying to help me. You know, there are big groups out there, whether they're research or professional groups, who don't even have a community representative. So they're trying to save the world, but they don't know actually if they're doing anything. And you know, one of my big bugbears is not having community advocacy groups on major boards. So our collaborations, when we put it all together, really do span a nation. We have people from universities all around the shop. We have huge overseas connections. And we're placing Australia on the map of driving arthritis research and engagement. One of the most important things that we all feel very passionate about in my group is mentorship. And Michelle and I have worked really closely of really looking after the people who we have charge over. And over the years, we've paid special attention to what are we supposed to do with each of these groups. So with the undergraduate students, we need to teach them what are the principles of research. For our postdocs and PhDs, it's about knowledge, how they present, communication, methodology, and helping them develop their track record. As they get more senior, it's about leadership skills. How should they go out and collaborate, and what sort of networks can they build, and what sort of networks can they leverage off? Because no point developing your own network, why don't you leverage off the next network that you're part of and grow that network, so that the footprint of Australia gets wider and wider and wider. And finally, even the senior researchers, we need mentorship as well. And we get mentorship from other CRE leaders. We go out and we find people who've been successful in what they're doing, because they're going to help us be opinion leaders and allow us to use our network to start setting agendas. So at the end of the day, as I said before, there are many factors. We're trying to fill these slots with people and groups who can help us make change. And one of the recent changes we've had is to bring in a completely different way of thinking. For example, with the help of Gavin Lambert and Anita Kossis, who Anita I think is over there, from Swinburne, have really revolutionised the way that I might think, and hopefully others might think, that when we talk about healthcare revolution, there is a huge bag of emotion that goes with it, and sometimes unpicking something when there's a lot of investment of emotion is very, very difficult. So we get the engineers in, because they've got a simple task. Let's have a look at the process. If we take emotion aside, how do we unpick and rebuild? How do we take the Volkswagen Beetle and turn it into a Ferrari from the parts that you have? And that's where we rely on this new way of thinking through the design factory. And through Anita, we've been able to connect with a global network of design factories. And this particular one in Finland has a major interest in the theory and practice of healthcare change. So what we're doing is learning from them about test beds and how you use hospitals. And we're lucky that in Australia we have a huge healthcare system that is united, that allows us to use that and practice translational care. So the outcomes of our work, that we embed research and training, we develop institutional efficiencies, practice and policy change, but more importantly, stewardship of a very finite resource. Why are we in an ideal position to do this research? Because we're affiliated with the largest not-for-profit healthcare system in Australia. Great testbed for translating. We have a universal healthcare system, which means whatever we do here, we can apply to the nation. It's not influenced by our neighbours. We have a standardised regulatory board. So we have a national training program. So the field of practice is unified. And Australia is an island. It makes us a great laboratory for the world. So my last slide is we have a unique opportunity through this CRE to design a model of care that will take us into the 21st century, to move away from 20th century practices. We should be aiming for developing this new paradigm, but more importantly, to driving leadership and having a global impact. Thank you.